Anything that we can specifically do? We've got these epidemiological terms, are not, IFR, CFR, these numbers that have become more public knowledge that the public wasn't initially aware of, that now people are throwing around like confetti on Twitter. Can you talk about what we know about these numbers and how we can potentially address reducing them?
Yeah, and then, thank you. This is a very important point because they get used a lot. I've been in this business 45 years. I've worked on a lot of infectious disease outbreaks and, published a lot. And I have to tell you, sometimes I am baffled by how much importance is placed on some of these. And what I mean, not so much that they're not important, but the precision which people are trying to measure something is actually quite imprecise. Let me give you an example. If one looks at the fatality rates, trying to understand, what percentage of people who get infected die, and you can determine how you want to call that, IFR or whatever, okay? And take a country like Korea. Early on, they were being touted as a country, they're doing something right. Their case fatality rates are really, really low. And look at ours. Well, when you looked at who was getting infected early on in South Korea, it was largely part of the religious sect. Many thousands where the median age was 38 years old. And so, of course, you would expect to see, just based on what we know for risk factors here, to see a lower case fatality rate. As soon as this got into older populations in Korea, numbers jumped right up, just like us. And where we had outbreaks early on in congregate living environments or congregate working areas, particularly in long-term care, we saw astronomically high numbers of deaths. Whether or not you provide care in your home or in a long-term care facility. In Asia, many of the older individuals in their society are cared for by their family in their homes. And so you didn't have these large, quote unquote, nursing home outbreaks in Asia that you would have here. So none of these have to do with somehow the virus acting differently in different countries. It's all about which populations were most exposed first that would then result in the potential difference. A good example in this country is if you look at in China, the rate of obesity in those over age 30 is extremely, extremely rare. If you look at those under 30, it's not so rare in China now. But if you look in this country and look at obesity starting in the teen years, it's much, much higher. So if you took two populations otherwise absolutely the same in age distribution as in China and here, and then try to compare what might be case fatality rates, it'd be totally different just by the underlying risk factors that are there already. And so I always had a bit of a challenge trying to parse out what's this doing or not doing. But let me just add context to this, I think. An event that I hoped I would never see in my lifetime, and I hope I don't see it again. And that is on March 1st of this year, COVID-19 was not in the top 100 causes of death in this country, not in the top 100. By April 20th, it had become the #1 cause of death daily for weeks. We had not seen that since 1918. That's the last time we saw that happen, 1918. Now, grant you, the intensive care medical community has done a remarkable job at better treating these patients, understanding without even new drugs, mechanical ventilation, issues around dealing with immune suppression and the whole immunologic response. They've really improved the care in a real significant way. So we clearly have seen the case fatality rates come down. In addition, of course, remdesivir, which is now available, may have had some marginal impacts. Steroids in general surely are having some impact. But so part of it is it's hard to compare the case fatality rates of today, even with April, just by what's happening there and that. But I come back to it in the end is I'm very concerned. Remember I talked about that 10 to 12% of the population infected. And if we're going to have to get to 50 or 70% to develop some aspects of herd immunity, again, that doesn't go away, it slows down. And vaccine's not a big part of that. For all the pain, suffering, misery, death, and economic disruption we've had, we have a hell of a lot more to go to get to 50 or 70%. So that's what we want to avoid. We don't want to have that happen. We're trying to keep infections low, at the same time, not just, burying society into even more pain and misery financially or otherwise. And that's the challenge we have going forward.